This is Charles Clinton on Part 3, Chapter 20 Summary from 11th and latest Bronwell's Heart Disease Edition, Coronary Angiography and Intravascular Imaging Chapter. So, what are the catheters for diagnostic procedures? They are in general composed of an external layer which is not thrombogenic or lubricious, and inside we can find a fine metallic core which gives it stability and improves maneuverability and reduces kinking. Lengthwise, there is a hub, a body, and a tip. The tip can be divided in different curvatures: the primary, secondary, and tertiary. It is from proximal to distal. Then the most proximal is the primary one. Diagnostic catheters have a thicker wall which considerably reduces their internal lumen. That is why diagnostic catheters usually cannot be used when we are going to do interventional hemodynamics, that is, or interventional procedures, because sometimes we need a larger diameter lumens. Catheter length is 80 to 110 centimeters, being 100 centimeters standard for femoral approach and 80 for brachial axis. Most commonly used are the Judkins and the Amplatz catheters. The Judkins left, or JL, we'll see the different curves it has and compared to the JR. Here we can see in figure 23, on the left we can see the left Judkins left, which has a primary curvature of 90 degrees. That is the proximal one. After that you find the arms. The arm is between the primary and secondary curve. So secondary curve is that arrow in purple, which is 180 degrees. That's for the left one. For the right one, it is less curved. It has a lesser secondary curve. That is why you can see 90 degrees the primary curve as the left one, and secondary curve is smaller. It's less acute, would be 30 degrees. Then left coronary usually goes into the coronary ostium in an automatic manner, while the right coronary needs an extra step, which would be clockwise rotation. So, probably or hopefully easier for a resident in practice or someone who is starting off would be the cannulation of the left coronary artery. Then we have that in general for femoral approach, the JL4 is okay. It starts off with 3, as you can see in the different terminal lumens of the catheter on the left. There's a 3, 3.5, 4, and 5. So depending on the length you need or dilation of the aorta, for example, you might need different characteristics. In general, for femoral approach, a JL4, and for radial approach, a JL 3.5. So the difference in 3 to 3.5 to 4 is the length of the arm, which is between the primary and secondary curve. Then we have the other type of catheter, which is the Amplatz, or which we have the AL has. It is pretty good for short left main ostium, a separate ostium of circumflex left anterior descending artery branches. And the Amplatz AR allows engagement of right coronary arteries with inferior orientation. Then we have the cannulation of the internal mammary artery. Remember, that is, we need catheters with highly angulated primary curved tip. We will see later on. Here we have on the top image the Amplatz catheters with the same primary and secondary curves. Then we also see, for example, on the internal mammary artery catheter, which has a very highly angulated primary curve. Then, for selective coronary artery cannulation for the left coronary artery, you have to advance the catheter until it reaches the aortic root. There, the catheter is rotated clockwise, the wire is removed, and the catheter regains its primary bend and should engage the ostium of the left coronary. Then we have the right coronary artery. The right is engaged in Lao. The left and right coronary arteries are engaged in the angiographic projection called Lao, which means left anterior oblique. That's why the mnemonic I made up as Lao equals Linda, with its first letter being an L. Linda, be it Spanish or English, is nice. So you think about a resident or someone starting off in the cath lab. You want to, once you cannulate the coronary artery, that's a big step for all you beginners, all us beginners. So Lao is equal to Linda, nice, well done, Lao. Right and left coronary artery are cannulated in Lao position. Then the right coronary artery, remember that you needed to rotate clockwise to engage the vessel. For saphenous vein grafts, in general, by convention, the right coronary artery, saphenous vein grafts to the right coronary are usually situated 5 centimeters above the sinotubular ridge, 5 centimeters above and anterolateral towards the right of the aorta, while the saphenous venous graft to the left coronary is anterior and 7 centimeters over the sinotubular ridge, and bypass that goes to the obtuse marginal. Remember that this is branches of the left circumflex, so it's on the left side of the aorta, anterolateral, 9 centimeters above the sinotubular ridge. And okay, here on the top picture you can see what happens in a normal aorta on A, trying to cannulate the left coronary, which is pretty automatic, while in B it's a little more difficult because you have a dilated aorta. So moving on, it says that if one or more saphenous venous grafts cannot be visualized, you should do an ascending aortogram, preferably in biplane. Sequential grafts, what are they? They are those that supply 2 different epicardial branches in a side-to-side fashion. In figure 20.6, you can see saphenous venous grafts in sequential format. The internal mammary artery, or the left internal mammary artery, is usually engaged in the Rao position, in the Rao projection. Then Lima que Rao. The mnemonic for this is from Spanish, Costa Rican common vocabulary, as saying Lima or Imae, which means hey man. Que Rao, alluding to an ass. So hey man, what an ass. Lima que Rao. This meaning that you cannulate the left internal mammary artery in the Rao projection. Okay, with a counterclockwise and gently withdrawn with the tip pointing in a cranial direction, allowing entry into the left subclavian artery. Remember that you have to go into the left subclavian artery, then go past the internal mammary artery ostium, and then when you're coming back, you should make this counterclockwise movement in order to direct the tip cranially and cannulate that internal mammary artery. Here you can see the same mnemonic, Imai Kirao, with the counterclockwise additional important step. And as you can see in the angiography, there you're inside the subclavia and not the aorta. That might lead you to know or think which is the artery and that this is a bypass graft. In this one, we can see radial grafts. So look at the curvature of this radial graft. It looks like a half circle or a rainbow. So if you see the radios that are the old radios, you can associate the radio with like a grabbing handle, a handle on it. That's the way you'll see radial grafts. Radius alluding to the radial artery and the handle alluding to the form you'll see in the angiography. Another option is looking at it as radius. So if you have half a circle, you can calculate the radius of a circle. So this graft has a curvature which is like a semiluna or half moon. So you could think that you have what is enough information to calculate a radius. Whichever works for you, fine. This is for radial grafts. This is what it reminds me in the angiographic projection. So for intravascular iodinated contrast agents, we have to remember that depending on its characteristics, it will produce certain allergic or non-allergic reactions. In general, the high osmolarity will generate much more, the denser and high osmolality will generate more reactions, around 12%, even 12 to 50% in some studies. And the low osmolality or non-ionic will generate low osmolality, and isoosmolarity will generate less interactions or reactions, 0.6%, with less than or equal to 20% being severe reactions. Then important points here is to remember that you should better choose non-ionic isoosmolar. And if there is no isoosmolar, choose non-ionic low osmolarity. If not, you're subject to a high adverse reaction rate. Automatic and manual injection of contrast media. You can do this manually in general, or with a new technology. You have a manifold, which basically is a constant modulation of the pressure of the injectate. So in general, at Costa Rican centers, it is done manually, but the information we need to know is that for the right coronary artery, since it is not that long artery, a little smaller than the left, you need 4 to 6 ml speed injection per second, and up to a maximum of 450 psi. While in the right coronary artery, you need to inject 6 to 8 ml per second, and the pressure will be a little more as well, 450 to 600 psi. Then right coronary 4 to 6, and left coronary 6 to 8 ml per second. Pressures up to 450 for the right and 450 to 600 for the left coronary. Then there's different. Look at table 20.3. In general, there's acute adverse reactions which may be allergic or non-allergic. The allergic ones are normal allergies we know of, and non-allergic are physiologic reactions to the medium, contrast medium. We corrected this table. We put an X on allergic like. No, that is allergic, because the allergic like would be the physiologic reactions. But we'll go into this in the next section.